Good morning, good afternoon, and good evening, wherever you are. Welcome to our third of our special webinar series on the impact of the COVID-19 pandemic on women and girls in developing countries. Our title today is Household Structures, Fertility, and Sexual and Reproductive Health and Rights in the Global South. Unfortunately, due to family reasons, Professor Sonia Laszlo could not be with us today, so I'll be a pale substitute. So my name is Frank Rimard, and I'm a professor of economics at McGill University. I'm also an associate member of the Institute for the Study of International Development and a member of the Center for Population Dynamics at McGill University. So as you know, this seminar series aims to engage researchers, policymakers, and practitioners on matters about women's empowerment and the impacts of the pandemic and a socio-economic crisis on women in the Global South. This particular webinar will discuss current issues around COVID-19, household structures, fertility, and sexual and reproductive health rights for women in the Global South. These three themes could be, of course, separate on their own, but they are really related, and this is why today we have got a wonderful panel of experts to discuss from the world of international development research and practice. We will discuss some research priorities as well as practical solutions. We will hear from Professor Sarah Brauner-Otto from McGill University, Dr. Agnes Quisembing from the International Food Policy Research Institute, and from Caroline Kwabonka from the European Parliamentary Forum. And we'll discuss their issues, discuss some of the issues we see, discuss some research priorities, and identify some possible policy solutions. So this is the third event in the series of webinars on gender dimensions of COVID-19 that are organized by the Women's Empowerment and Development WED Lab at McGill University in partnership with the Institute for the Study of International Development. It is made possible thanks to fundings from the Growth and Economic Opportunities for Women, the GROW2 program, a multi-funder initiative by the Bill and Melinda Gates Foundation, the William and Flora Hewlett Foundation, and Canada's IDRC, the International Development Research Center. So while we're meeting virtually here across the globe, this series and the lab are hosted by McGill University, which is located on land which has long served as a site of meeting and exchange among Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. Before introducing our panel, I would like to introduce the team. Leva Rouhani, who will moderate the panel today, and Martha Meles from IDRC, and I invite her to say a few words. Martha?
Yes, I was muted, sorry. Thank you, Frank. Good morning, good afternoon, good evening. Welcome everyone to our third webinar series on gender and COVID-19 in the Global South. My name is Martha Meles and I lead the IDRC's Employment and Growth Program, which houses the GROW initiative that Frank mentioned. For those who may not be aware, GROW is a 5-year action research program jointly funded by the Bill and Melinda Gates Foundation, the William and Flora Hewlett Foundation, and IDRC. The goal is to find scalable solutions for advancing gender equality in the world of work with a focus on East Africa. And the program has 3 thematic priorities: addressing gender segregation in employment, reducing and redistributing unpaid care work, and unleashing women's collective agency. And a shout out to my GROW colleagues, Jemima Njuki and Paul Okwi in Nairobi, Erin Andrews and Lisa Gan in Ottawa, and 2 colleagues at WED Lab who have partnered with us on this webinar series. Now, there are multitudes of webinars these days on COVID-19. So you may ask, why this webinar series and what's the value add? We hope to spur informed discussion on how COVID-19 is impacting women's lives and livelihoods, why gender matters in COVID response and economic rebuilding, and opportunities for building back better in low and middle income countries. And as we're seeing, the impact of COVID-19 is far-reaching. It's also gendered, affecting men and women in different ways. In the last two webinars, we engaged diverse experts from the Global South to reflect on how the pandemic is impacting the livelihoods of women in the informal sector, and how this has also increased the demand for unpaid care. And today's webinar will focus, as Frank said, on the impact on family dynamics. So how does it affect household structures, fertility, sexual and reproductive health for women in the Global South? Available data suggests that close to 2,000 clinics and community-based care outlets were closed as a result of COVID in Asia as early as April. And the number was 450 mobile clinics in Africa. And we know that the number is expected to have increased as social distancing measures continue to be enforced, and in the face of the lack of access to PPE. Many have been forced to cut sexual and reproductive healthcare services, and marginalized women and girls are the hardest hit. So with this context, I really look forward to hearing from our panelists on how this is playing out in different countries, and to exploring opportunities for building back better. So without further ado, I turn the floor back to you, Frank, to lead us into the moderated panel. Thank you.
Great. Thank you, Martha. It's a great setting for introducing our panel today. And as you pointed out, our series are quite different from all the other series because we try to integrate this research to policy angles. And that's why our panel today recognizes that. So our first panel member is Sarah Bronner-Otto, and will represent the researcher point of view from the academic side. And she's the director of the Center for Population Dynamics at McGill University. She's a social demographer studying global family changes with a focus on the relationship between social contexts and demographic behaviors over the life course. Her research has basically three axes: social influences on global family change, macro level perspective on social organizations and fertility, and methodological tools for studying global family change. The COVID-19 is certainly quite a big shock, and that will have consequences, that has consequences right now, of course, but also will have more consequences in the future. So certainly our demography angle will be quite interesting to see. Our second panel is on a mix of both research and policy as well. Agnes Kinsubing is a senior research fellow at the International Food Policy Research Institute. IFPRI is based, as you know, in Washington, D.C. And she leads a cross-cutting research team on gender. She received her PhD and MA from the economics at the University of the Philippines in Quezon City. And she was a Fulbright Hays Fellows at Massachusetts Institute of Technology. She was a visiting fellow at the Economic Growth Center at Yale University and was an economist at the World Bank before joining IFPRI. She's published widely on gender, intra-household allocations, women's empowerment, property rights, poverty, economic mobility. She's done fieldwork in Bangladesh, Ethiopia, Ghana, Indonesia, and the Philippines. She's a co-developer of the Women's Empowerment in Agriculture Index, WEA, and the new one, or the modified one, the project level Women's Empowerment in Agriculture, the ProWEA. She's also a co-editor of Gender in Agriculture and Food Security, Closing the Knowledge Gap. Our third member of the panel represents more the field, the practice example, and it's Carolyn Kwambolka. Very sorry, Carolyn, for your name. Is a policy expert, and she has 18 years experience in the field in advancing gender equality and women's empowerment and sexual reproductive health and rights in sub-Saharan Africa. She's currently the focal point for Africa at the European Parliamentary Forum for Sexual and Reproductive Health. Ms. Pambunka currently coordinates capacity development efforts and engages with parliamentary committees and caucus to inform legislative and policy actions across Africa. She also serves as a Global Advisory Board member for Women Lift Health, an initiative at Stanford University, and she's the interim chair of the Advocacy Accelerator, an innovative platform that equips grassroots and national advocates with evidence, information, and tools to drive greater impact on the issue of sexual and reproductive health. So as we go right now, I'd like to remind you how the webinar will unroll. Each presentation will have about 15 to 16 minutes to present. At the end of the presentation, the 3 presentations, it will be a moderated roundtable, by Leva, and where the panelists will take questions. And the roundtable itself will begin by asking the panel members to propose a possible research priority and or policy solutions to the gender dimensions of COVID-19 in household structures. So for those of you who are on the webinar right now and you want to have questions, as you know, if you're using Zoom, and if you've been using Zoom, there's a chat box, and that's the bottom of your tool at the bottom of your screen. So you're more than welcome to raise questions in the chat that the moderator will then pick up and ask to our panel. And some of our panel members might also be able to answer directly and try to do it. So please feel free to use this tool so that we can collaborate and have a great meetings in terms of that. So without further ado, then I will turn to Dr. Sarah, who will then discuss her point and will then go to the other panels. So thank you very much. I'm sure you'll enjoy this very interesting discussion today. Sarah?
Okay, thank you very much for the introduction and for having me here today. I'm going to give a brief overview of how I think we should conceptualize the implications of COVID-19 for fertility in low and middle income countries. I'm not going to present any data. It's really too early to see any kind of changes in births or anything like that. So just really a thought presentation. And also this is a fairly broad level presentation, but I'm happy to try and answer more specific questions that might come up during the question and answer thread. And apologize, it's COVID-19, so you will see my family in the background of the presentation. Okay, so the link between mortality and fertility is really at the heart of demography. And what I'm going to do in this presentation is walk through this demographic perspective to assess the link or potential link between COVID-19 and fertility in low and middle income countries. And I'm going to do this by asking 2 questions. What can we learn from core demographic principles, and what can we learn from the past? So first, the demographic principles. When demographers think about fertility, we start with the proximate determinants. These are the variables through which any social factor, like a pandemic, could influence fertility. So here they are. They can, we can think of them falling into 3 categories. Here we have exposure to sex through exposure to unions, abstinence, and coital frequency. Also exposure to contraception and gestation. Now, it turns out that when you look across settings or over time, not all of these are equally important. And it's these 4 in red that explain the most variation in observed behavior. So we can walk through how we might expect COVID-19 to influence fertility based on these 4 key proximate determinants. So first we have the proportion of a population that's married. Here, I think we'll hear more about marriage and household formation later on in this webinar, but just briefly, what I would anticipate is that we will have seen and will continue to see a delay in marriages due to COVID-19. In the short term, you have the lockdowns, which would have prevented some marriages from taking place. And then in the long term, I would expect to see lower marriage rates as a result of the economic problems arising from the lockdown. Of course, many of you may be wondering why I'm focusing on marriage. What about non-marital cohabitation? Well, historically for demographers, formal and informal marriage were far more relevant for fertility, and I'm certainly thinking of informal marriages in this discussion. Sorry, I'm just going to try to look. Okay, sorry. Trying to look at the Q&A and keep on top of the questions as they come in. So formal and informal marriage are both included in my thinking about this. Of course, non-marital cohabitation that's somehow different from informal marriage is much more widespread today and something we need to be thinking about. My sense for thinking about this with COVID-19 is that while there may have been a small number of couples who decided to cohabit when lockdowns began, it's unlikely that many people anticipated the length of these measures and probably didn't speed up their entry into cohabitation in anticipation of a lengthy lockdown. So in the short term, even though you don't have the legal barrier, like one that would stop a marriage from happening, I don't think you would see many people switching to cohabitation during the lockdowns. Afterwards, we may see some increase in people deciding to cohabit. Maybe the economic crisis is moving them away from marriage or out of single living. But my gut right now is that this is, well, certainly right now we are not seeing that effect. So the second kind of major proximate determinant to be thinking about is voluntary infecundity. This comes largely from breastfeeding, which I think is unlikely to have changed as a result of COVID-19. Oops, my arrows aren't in the right place. Sorry about that. So then we have contraception. Lockdowns may have contributed to decreased access to contraception, which would lead to an increase in fertility. And similarly, we would expect something similar for abortion. So what we really need to be thinking about are the magnitude of these potential effects, and then how could COVID-19 influence these proximate determinants themselves. As a substantive question, could we not expect an increase in marriage due to economic reasons? I'm going to table that question for the Q&A because I think it's a really interesting one, and I'm worried I would go way off of my time limit if I started talking about that right now. Okay, so when thinking about how COVID-19 could influence these proximate determinants themselves, we want to think about, could it have changed people's preferences for children, or say using contraception to avoid a pregnancy. And so for that, I'm turning to these more theoretical pathways of influence that demographers are talking about. So to start, we can think of these biological pathways. How will the disease and related mortality directly affect fertility? We may see some small decrease in fertility through this path. There could be kind of fecundity repercussions for having been infected with COVID-19 and recovering, although we really don't know that yet. Regarding mortality, we could expect some decrease in fertility due to deaths of people of reproductive age, but really it's unlikely that we'll be seeing this on a population level. And so this is kind of where demographers are focusing their attention, is on these population level trends or patterns. So key here is the age profile of COVID-19 mortality. Most people who are dying as a result of COVID-19 are older, so they're not currently of reproductive age. So them dying isn't going to leave us with a shortage of people having children in a country, and nor are we likely to see smaller cohorts of reproductive age people going forward, which is something you would expect if there was a childhood epidemic. Now, having said that, it's quite likely that the age profile of COVID-19 will be younger in low and middle income countries than it is in wealthier countries. I haven't seen the data necessary to confirm this. I just haven't been able to get my hands on those data, but it does seem that COVID-19 mortality is still concentrated in older ages. So that's where we would expect to see changes in the age structures. What might be more likely for seeing an influence of COVID-19 onto fertility are behavioral pathways. So we might see some postponement in fertility because people decide that during a pandemic is not a good time to get pregnant. This is particularly likely because of the massive economic problems that we're seeing. So we would expect that fertility will decrease during the epidemic period itself and then increase right after, as you have both couples who were already planning to conceive and the couples who postponed their fertility during the epidemic conceiving in that short term. But in the longer term, we wouldn't see this effect continue. Another pathway commonly discussed in demography is the replacement idea. So having children to replace those who died. And this could happen at the couple level, replacing own children who died, or also at the community level with broader social forces encouraging widespread childbearing to rebuild communities. And there is some argument that that community replacement or rebuilding effect will be greater in rural or tight-knit communities where people may feel the pandemic-related mortality more as a community loss and therefore feel motivated to replace those people who have died. But both of these also tend to be fairly short-term effects. Related to this idea of replacement and rebuilding are ideas about children as insurance. So the fear of the pandemic leading couples to increase fertility to ensure they'll have enough surviving children. For the couple kind of replacement fertility that I mentioned, we would expect this more if there was high child mortality. And we would expect the insurance effect if people anticipate that the high mortality will continue into the future, thereby limiting the chances that their current or immediately planned children would survive to adulthood themselves. So to the extent that a wave of COVID-19 doesn't change expectations about future child survival, I wouldn't really expect to see this insurance mechanism at work. But finally, what I have here is a whole kind of separate bullet point about economics and broader changes in preferences. So COVID-19 hasn't just affected mortality and morbidity, it has sparked massive economic downturns. And in general, fertility is lower during poor economic situations and also lower in the face of uncertainty. And both of those, I think, are really pressing right now and shaping families. And they're shaping their actions and their preferences. So potential parents may feel that they're not able to support children in the way that they want and then decide to have fewer children or to delay their childbearing. At the same time, though, there are also some arguments often employed when discussing low and middle income settings that families may respond to poor economic situations with higher fertility because those children may be a more reliable form of investment or capital. When we do see evidence of this in the empirical literature, it seems to apply to the least well-off in a population. And I think it really points out that when we are looking at these relationships in the future, when we have the data to look at it, we should consider the potential for heterogeneous effects within each setting. Okay, so that's my brief demography lesson. So what type of empirical evidence do we have on these pathways from past pandemic type experiences? I think there are three bodies of literature that might inform our predictions regarding COVID-19 and fertility. First, we have the 1918 flu pandemic, then thinking about other diseases like Zika and AIDS, and then finally natural disasters. Okay, so with the 1918 flu pandemic, there are 3 really notable studies of this. The first is a thorough study using Swedish registry data and exploiting the variation in the epidemic mortality. They find that the effect of the epidemic varied over time on fertility. So they saw a decrease during the epidemic, then a sort of postponement catch-up in the short term, that was concentrated among the higher status and wealthier who were better able to navigate the poor economic situation, and then a decrease in the long term. And the authors say that this is because the massive economic insecurity at the time lowered marriage rates, which decreases fertility. Then there were 2 cross-sectional studies which concluded that birth rates first decreased similar in that sort of immediate term and then increased later on. But the timing measures across these vary quite a bit, so it is a little bit difficult to make concrete conclusions about this. But I think what we can say is that the effect of the pandemic on fertility changes over time. It's not clear exactly when you shift from short-term to long-term, but we should expect to see sort of some fluctuation in fertility over time. Or rather, we should expect to see this fluctuation over time if we think that COVID-19 is going to affect fertility similarly to the 1918 pandemic. And I think the answer to that is not necessarily. Like maybe this isn't the best comparison to be making. So as I said, the age profile for COVID-19 is associated with higher morbidity, mortality in the oldest ages, but the 1918 flu, the peak mortality was for young ages, in particular for reproductive ages, and it was also quite high for children. So we wouldn't expect those same kinds of immediate decreases in fertility due to dead and sick people that we saw in the 1918 pandemic. So we'll see maybe less of a replacement effect happening, but I think that the long-term decreases due to economic issues are likely quite relevant. Okay, I'm seeing a lot of questions coming in, but I'm gonna wait to address them at the end. So what about other diseases? Are there other more recent epidemics, global diseases that might be more relevant? Some people have tried to make comparisons with Zika, where we have seen fertility decline in response to Zika, but this work is really showing that the fertility decline is a response to knowing that Zika causes birth defect, not knowing about the illness itself. And we don't right now have any clear evidence on the link between COVID-19 and birth outcomes. There is some evidence that it might lead to premature birth, which could be quite relevant, but all that is quite preliminary at this time. People have also thought about HIV/AIDS comparisons, and again, we have some evidence that fertility and desired fertility is lower in reaction to infection. But here, I think that the demographic, contextual, and disease profile of HIV/AIDS is quite different from that from COVID-19. So this one, it's not immediately clear to me that there are comparable situations. What about natural disasters, seeing as the pandemic was somewhat sudden, unexpected, and has certainly been very destructive? There is some evidence that fertility increases after disasters, particularly finding support for the replacement and rebuilding pathways. But again, the comparisons to COVID-19, when we really push into it, I think are quite thin. You can't really say that COVID-19 was unanticipated. Maybe the first wave that we saw in China, but once we knew this was coming, we knew that it was going to be spreading. And the destruction of the event plays out very differently for this pandemic than with something like a tsunami or an earthquake. Okay, so just to kind of tie things up, what I've discussed isn't necessarily particular to low and middle income countries. So are there additional considerations for these specific settings? Yes, of course. As I mentioned, it's possible that the age profile will be very different in low and middle income countries than in wealthier countries. We do know that places like India are seeing a large share of deaths coming from younger ages, but those populations are also much younger than places like Canada. So it may be that the higher proportion of deaths at younger ages is simply a function of the age structure of the population and not reflecting differences in the profile of the disease. And we really need to get the right data to ascertain whether the age-specific death rates are different. But it's quite reasonable to think that the age profile will be different because many low and middle income countries are dealing with underfunded and under-resourced healthcare infrastructures. I was just reading an article about this yesterday, specifically about hospital overload in India, which could certainly lead to higher mortality for younger people. Also, many of these countries have a higher proportion of the younger populations with comorbidities, which would further change the profile. So if we think about HIV, AIDS, and tuberculosis are far more prevalent in these countries at younger ages, that could really shape the mortality impact of COVID-19, which would certainly lead to different effects on fertility. Yeah, so if COVID-19 does lead to substantially higher morbidity and mortality in younger ages, particularly the reproductive ages, then we can see substantial fertility effects. Here, I think we have reason to expect similar effects as we're seeing from the 1918 pandemic. I'm gonna, quickly go through this. Another issue is the access to contraception is really tenuous in many of these countries. If the economic problems created by COVID-19 and subsequent lockdowns are so severe to disrupt these branches of the healthcare infrastructure, we could really see an increase in unmet need for contraception. And then another issue is that in many low and middle income countries, childcare infrastructure is not well developed. And there's an assumption that when people are planning their families, they're counting on grandparents as being caregivers for their children. If COVID-19 means grandparents aren't there, families may reassess their fertility plans. And then finally, I just want to point out that the overall trend in most of these settings is for fertility to be decreasing. So I think COVID-19 may push that trend along faster or farther. If people are already starting to think that smaller families are more tenable, the uncertainty associated with COVID-19 in terms of health and economics may strengthen those ideas and preferences. And it would have to be quite dramatic to reverse that trend. So thinking about what kinds of policies could kind of counter that would have to be quite huge investments from governments that are going to be really straining as a result of the economic situation. So overall, I think we could see some negative effects of COVID-19 on fertility, and that positive effects would likely be limited to those due to lack of access to contraception and not to an increased desire for children. So thank you. I'm very sorry that that took me so much longer than I practiced. Sorry.
Thank you, Sarah. This is the life of COVID-19. These webinars as well are the way we go. So, you know, this is great. And thanks for trying to pick up some of the questions of the Q&A as we go. And of course, we'll have a series of questions later on. And please send in your questions so that we have an interaction with our panel. Our second panel member is Agnes Versimbing from the International Food Policy Research Institute. Agnes, this is your turn now.
Let me unmute myself.
Yes, you're fine now.
Okay. Can you see my screen?
Yes.
Okay, very good. Thank you, everyone, and thank you, Frank, and thank you, Sonia, for inviting me to this webinar. I would have loved to be in McGill, but that is not the case, and so we will have to deal with webinars in the time of the pandemics. So I'm going to talk about inter-household dynamics in the time of COVID-19. And to give you some perspectives from the global south, like Sarah, I'm going to be drawing from a lot of the work which was done um, in the context of previous crises and pandemics to look at how this pandemic would affect.
It's moot now because I'm done speaking, but the next time I have to give a presentation, shouting from the other room while I'm actively talking is extremely disruptive. I'm sorry. Sorry, I thought you were on your. I was, but you can hear things, and it's just.
May I continue? Okay, may I continue? Okay, so I'm going to start from a perspective of inter-household decision-making, which is an area of ongoing research, with the idea that many decisions that affect individual well-being occurs within family and households. This is true in normal times. It's also true in pandemic times. What we have seen with COVID-19 is that it magnifies inequalities in society. And I would also not be surprised if COVID-19 also magnified inequalities within households. So how do inter-household dynamics change during the pandemic? In many cases, lockdowns have made the sphere of mobility, the sphere of action of many households changed. Just like this woman in India is, she's now confined within her courtyard with her children. How does this change into the household dynamics now? So what do household models tell us? So let's say that since I'm an economist, I'm going to start with the idea that what you want to do is to maximize the well-being of individuals within a household subject to the resources that the household has. In the past 2 decades, economists have been testing models of household behavior, looking at models which say that households behave as one, whether they share common preferences or a dictator, and that households pool resources. And the other model that has become more influential is the collective model, which assumes that household members have different preferences and that members do not necessarily pool resources. So the prediction of the collective model of the household is that one's share of resources depends on bargaining power within it. So what determines bargaining power within the household? One is control of resources, such as assets. Another is mobilization of personal and social networks. Another would be basic attitudinal attributes such as self-esteem, self-confidence, emotional satisfaction, and outside options, including social protection mechanisms. How are these all being affected by the pandemic? We still have very little data, but we can look at what we've learned from past crises. So in the terms of assets, for example, we take a look at lessons from food price shocks in 2007, 2008. Neha Kumar, Julia Berman, and I took a look at households which were experiencing a range of shocks during this time. What we found was that in Bangladesh, households that were experiencing a food price shock tended to protect jointly held land and assets, but not individually owned assets. Illness shocks led to a disposal of women's assets, so women's assets were the first to go. In Uganda, households that were experiencing a food price shock protected the husband's assets, but not the wife's or jointly held assets. So it seems that households typically protected the main livelihood asset. Now the implication here is that if women's assets are the first to be disposed of during a shock, it has implications for her future livelihood and bargaining power within the household. It would tend to erode her bargaining power because her assets go first. Now let's look at another dimension of bargaining power, which is social networks. So physical distancing guidelines and lockdowns often reduce access to social networks. It's important for women, especially for those who belong to women's groups. So for example, a lot of Civil society organizations have organized women's groups and deliver services through them. So it isn't only that women may lose access to those services which are being provided by the groups, but they may also lose access to their social networks, which are a very important source of social capital. This is also important for men. Men don't have access to their peers, whether in work or in neighborhood gatherings, and it could also lead to increasing stress for both women and men. Okay, let's see. I want to go to the next slide. Why is this not allowing me to go to the next slide? Okay, so self-esteem and self-efficacy. Economists know less about this. This is the area that psychologists know very well. But it's often linked to having a life outside the home. So we have a recent paper which is coming out in PLOS One, which looks at mothers, poor Indian mothers, some of whom are members of self-help groups and others who are not. And what we find that mothers who self-identify as farmers rather than as housewives, and those who are self-help group members, are less likely to report chronic mental disorders. Now, COVID-19 has eroded livelihoods for both women and men. This is very stressful. Is it the case that a stressful situation plus a lockdown would increase rates of intimate partner violence? We're seeing some reports from police and hospital data, and this is something that we need to look at more carefully because there's also likely to be a lot of underreporting. Social protection. A very important outside option that's linked to increases in bargaining power for women is social protection. For example, conditional cash transfers and unconditional cash transfer programs. So one of the things that's been very common in social protection programs, for example, is making the beneficiary or the recipient of these transfers the woman. But rapid assessment of initial COVID-19 social protection responses indicates that only 11% show some gender sensitivity, and the others are not. And social protection mechanisms and programs have had to sort of re-engineer themselves to follow, for example, social distancing, which you'll see in these two pictures on the right. So they're 6 feet apart as they line up for transfers. Many things remain unknown. And really, it's very hard to get at what the impacts are on well-being and empowerment without face-to-face surveys. Now, you've probably heard that everybody's doing phone surveys now. Certainly, we are also undertaking phone surveys. But they're not a panacea. There are huge gender gaps in mobile phone ownership. Overall, worldwide, there's only an 82 mobile phone ownership rate for women. And this varies across countries and across income groups. And even if you are able to contact a woman, it's very difficult to guarantee confidentiality. So we're doing some work with the SEWA, Self-Employed Women's Association in India. And many of the respondents say that their husbands or other household members ask them to put the speakerphone on. So you really cannot guarantee confidentiality, and if you can't guarantee that, you might actually be endangering your respondent. So I'd like to end here with questions for research and policy. We really need to know what interventions work best, which interventions are protective. How can we design interventions to be more gender sensitive? What are the long-run and short-run impacts of COVID-19? And how can interventions help to alleviate them? So I'd like to stop here and thank you, and look forward to engaging during the Q&A. Thanks.
All right. Thank you, I guess. This is great. So Carolyn Kwabonka, now from the European Parliamentary Forum, will then discuss her point of view, and we'll go on to a sessions of moderated by Leva.
Thank you very much. I think the moderator could switch my video on. lever. Okay. Thank you. Thank you very much. And, much appreciation to the speakers that have gone ahead of me to articulate some of these issues that are affecting women, especially in the global south. So this evening, I would like to just bring us a little bit before COVID and share some key statistics. These were compilations that was recent as at the end of 2019. And we have the latest, or rather recent statistics having it that 830 women are losing lives daily while giving life. That means during the maternal process, either before delivery, during or after. We have also been noting about 33,000 girls being forced into child marriage. And this is even before the crisis. Another 11,000 having their genitals cut daily, with very high infections of HIV, mostly among the young people. And this was recorded at about 5,000 by the end of 2019. Already there was a stretch in terms of accessing basic health and education and even care, even without the crisis. So this is the situation that was already on the ground. So when we look at the next slide in terms of the annual indicators, we have records, or we have statistics telling us that 1 in 5 women are already, being assaulted by their partner, or will be, or at risk of being assaulted already. And then we have cases of intimate partner violence already at play. And I think this one has been shared already by the speaker before me. But more than that, we also have a lot of violence that is motivated by the perception of sexual orientation and gender identity. And just the perception is enough to have different men and women and young people at risk of this violence. When we think about the global south, especially in Africa, issues of conflict, political unrest, natural disasters are ongoing, regardless of the situation, or regardless of other emergencies. And already at the end of last year, we had 5 million pregnant women displaced due to conflict. And we also had a global figure of about 214 women around the world being unable to prevent pregnancy because they did not have access to the contraceptives that they wanted. So this is already a bad situation. Then in comes COVID in the next slide. When we look at what is now happening, it's that, next slide please, Leva. We note that the COVID-19 circumstances have only come to increase these vulnerabilities. There is a lot of, there is reduced access to SRHR services, and I think Sarah alluded to that earlier. Due to the lockdowns, we have inequalities quite exacerbated because these are manifested through the restrictions and limitations to women's opportunities in education. Already I could see in the Q&A a mention of the impact of closing schools, what this is having, actually what impact this is having on the family, on the household level, having these children stuck at home, unable to be in safe spaces, and therefore at risk of exploitation and abuse, even with those who are expected to care for them. The full participation in society is greatly hindered because interactions outside the family unit are restricted. And we have also noted through all types of media increased cases of sexual and gender-based violence. Now, what makes this very complicated is that there is violence on one hand, but even worse is the cutoff from essential protection services. The cutoff from social networks that are normally strong in terms of supporting, cases of abuse or cases of trauma. These are already disconnected because of the movement restrictions that are currently in place due to COVID. The issue of diminished livelihoods has also come out very, very, very strong. A big portion of the population traditionally would depend on daily kind of earnings, especially in the urban areas and even in the rural areas. There is the casual labor or going to work in the farms, which is not necessarily the case anymore due to all the limitations that COVID brings. And this has brought about economic distress, caused a lot of social vulnerability, increased vulnerability and exploitation. And just to reiterate, the mental health issues have actually been increased, or these are largely manifested and are made worse because the access to the points of service delivery, access to regulation, access to enforcement and justice is simply not working. The wheels of justice are not working. So this is just to share with you that what we are observing on the ground already is making a bad situation, a situation that was already bad, only worse. So when we go to the next slide, I think it's also important for me to share in this forum that all this is happening against a backdrop of plenty, and this plenty is basically in reference to the policy provisions that are in place to protect the populations against abuse or to help advance the protection of sexual reproductive health and rights and access. And these are quite a lot of provisions that are already in place, however, not practicable under the circumstances. When we look at in the next slide, there is also a whole list of policy provisions that are available in Africa specifically, and I would like to just speak into this. Most of the countries across Africa already signed into these protocols that allow for the protection of sexual reproductive health and rights, that allow for progression or progressive policies to be put in place, and for legislative protection and allocation of resources to be put in place to care for these issues. However, the challenge now is that the existence of this policy is on one hand, and on the other hand, the legislative system and the policy providers are hard pressed to utilize every single resource that is in place COVID response. That means that there is all these provisions, or the possibility of implementing these provisions is brought down to a nil, because because the priority is now to do the COVID response. So in the next slide, we look, this is just a continuation. Yes, thank you. So there are gaps that we must address. There are gaps that are really coming out very, very, very clearly. And these gaps are bringing out key questions that we need to consider. One of these is really that as much as the policy structure or the legislative structure has provisions, the law awareness, on the other hand, is undermining women's and girls' rights access. we are seeing that women and girls, girls, especially the young ones, the teenagers, are now at higher risk of teenage pregnancy. We just had a recent report reported in Kenya in one particular district where over 4,000 girls have been found to be pregnant, and they are all under 18 or under 19. So all this has happened just in the period between December and now. We also have, the patriarchal norms taking then the low recognition of the essential needs of SRHR within the community or within the families is now, of course, in the next layer. It's not being taken into consideration. We also have a lot of limitations among the households themselves, because the social, cultural, financial, and all these other barriers that have now been accelerated due to COVID are just increasing the distance between them and what they are able to, what they could be able to benefit to secure their rights at that level. And then we also have different upstream challenges. In the next slide that I would like to share, that have to do with systemic assessment, monitoring, and tracking mechanisms. And this is over and above. So on one hand, all these abuses are not being tracked. The violations to reproductive health and rights issues are, the mechanisms to track and address those issues simply don't exist, or in places where they exist, they are not able to be activated because the COVID, or rather all the attention has been diverted to COVID. We also have limitations in human resource, which makes it even harder and undermines the transformative potential that all the policy provisions that we talked, that I've just shared briefly about, could have. And we can only imagine that this will get worse because the pandemic is now, at a very accelerated point when we talk about the southern countries where, it came slower, but is now at its point of acceleration. So when we look at all these challenges, it is clear that the COVID circumstance is likely to really increase and undermine access to sexual reproductive health and rights. It says it is very difficult to have the policies implemented because the attention is diverted. Meanwhile, a lot of abuse and exploitation continue below the surface, or below the radar of monitoring, and the impact is something that we can only anticipate will be worse in the next, or will continue getting worse in the next few months. So I would like to just stop at that point and welcome. I think there are some questions that were already being raised, and some of those issues we've touched on, but I look forward to further interaction in the Q&A session. Thank you.
Thank you very much, Carolyn. It's very interesting. I note that, for instance, in Canada, yesterday, the Minister of International Development actually announced a series of new funding for SRH, both at the multilateral level as well as some specific countries. So I'm sure perhaps some of the panel participants, the audience, might want to raise questions about that. I now turn to Leva, who will then moderate the roundtable to have this discussion going, and also invite everyone to use the Q&A dialogue box to actually raise more questions as we go along. So thank you. Leva, it's yours.
Thank you, Frank, and thank you to our great panelists for raising many interesting and important issues today. So I'll start the moderated roundtable by asking each of the panelists to discuss, given the current context, what should be the research priorities and or some key policy solutions for our audience to be thinking about, to be considering, to be going into more deeply. I'll open the floor to Sarah, and this will be followed by Agnes and then Caroline.
Okay, thank you. I'm going to try to address some of the questions that were raised as I do this. So the first thing that I had listed as a real priority is to better understand what COVID-19 looks like in low and middle income countries. You know, is the age pattern of mortality different? And then also to address one of the comments, what does morbidity look like in low and middle income countries? So what does it mean to have gotten COVID-19 and recovered in these settings? And that's certainly going to be affecting younger people. And you know, if COVID-19 is essentially creating a generation of people with long-term disabilities, that's really going to affect family formation in these countries. I think we most definitely need to understand the economic consequences for COVID-19 in these for families in low and middle income countries, both in terms of concretely what's happened for loss of jobs and loss of income and isolation, but also how does that make people feel? Do they feel uncertain and unstable? How has access to contraception changed? Clearly, this is an issue already plaguing many countries, and how has COVID-19 exacerbated those existing problems and inequalities? And yeah, kind of to reiterate what my other co-panelists mentioned, you know, really thinking about the inequalities that already exist and how COVID-19 is perpetuating them or worsening some of these inequalities that exist in terms of pushing children into early marriage, for example, is one of the important points that people raised in the comments. It's clearly, you know, to the extent that this is happening, this will have some fertility implications, and we really do need to get data to understand how this is playing out. Okay, I think I will stop there.
So it's my turn. You can turn the camera on if you like, Leva. So I think some of the things that I'm very interested in finding out would be first to find out what's actually happening on the ground. I think we don't fully know what's going on within the household because we are unable to talk directly to women and men within those households. However, this may be a way, I think that women's groups, the groups that women belong to, and I hope still belong to even during the shutdown, might be a solution to many of these issues. To find out first, to be able to check in with the woman herself, how she's doing, and also to provide a way for her to access other services. So for example, we have been in touch with our partners implementing organizations in Bangladesh and in India, so BRAC in Bangladesh and Pradhan in India, who have actually mobilized very quickly to continue to use their existing platforms to deliver social services. So for example, we have been working for a couple of years with Pradhan, which is one of the large NGOs in India, that has a self-help groups platform, and they have been now using their self-help groups to run feeding centers for migrants. We're looking into working with BRAC to continue delivering extension messages remotely to the members of a nutrition-sensitive agriculture intervention. I think it's very important that the services still continue even during the pandemic. I would like to see what can be used or what can be done to make social protection more effective. What we've found, because we've done a lot of work on social protection before pandemic times, is that cash transfers targeted to women improve their bargaining power in the household, and also improve other outcomes. So how can cash transfers be provided? How can it be provided in larger amounts so you reduce transaction costs? And how can they be better targeted to women? I would like to find out more about what's happening to women's agency. It's very hard to have long-term data on women's empowerment, but I'd like to see whether women who are more empowered before the pandemic are able to come out of it better, whether they're able to weather the storm better and how they're coping. So I want to stop there. I think that's, to actually do that research agenda means being able to go back to the field, but we cannot go back to the field yet because we would endanger our respondents. So it's really not ethical to put them at risk for the sake of research. Thanks.
Okay, thank you. I guess it's my turn now. I think one of the key things that I wish to share is the kind of efforts that legislators and policymakers are making to ensure that there is fair redistribution of resources, and on one hand, and on the other hand, really fair and updated review of policies that are in place so that the protection of the most vulnerable can be undertaken and sustained. So this is one thing, and practically speaking, we are working with a group of champion parliamentarians that are drawn from all countries in the South, including Asia and Africa, to really impress upon the executive the need to advance protective policies and resources that can take care of not only of sexual reproductive health and rights needs of the women and the young people who need them, but also to connect this to economic empowerment opportunities that are necessary to secure those who are likely to be, left vulnerable at the household level. But having said that, I think there's something very important about the policy, streams that need to be in place. And there is the, sort of the global framework which covers the country or covers the systemic issues within a country. But more than that, we are also seeing the need for policy change to take place in institutions, for example, at points of service delivery, like hospitals, to advance, to make it easier for those who may need, their ARVs, STI treatment, family planning services, safe abortion services. That this policy, the operationalization of the frameworks needs to also happen at the institutional level. And when we come lower, as much as a large part of the women may not be captured in at places of work, where institutions or workplaces exist, and there's a lot of women. We have a lot of farms here. We have a lot of field farms, flower farms, industries, places where women are frontline service providers or are trying to earn their livelihoods. These are also places that need to embrace the kind of policy change that we are trying to advance, so that the woman or those who are easily ostracized can feel secured, and that they can have safer spaces from which they can operate and continue supporting their families from. So this kind of, how we embrace provisions that are in place and how we operationalize them will be key to secure, the women and guard them against this very hostile environment that they find themselves in. Thank you.
Thank you so much for providing some research priorities and policy solutions to this ever complex issue. So I'll begin by going to the Q&A, and we have some really great questions coming through. Feel free to keep sending them in. I'll start with one question that we got with regards to a context when we don't have a lockdown in place. So what are the consequences of COVID in countries where there are no quarantine or lockdown measures? For example, in Belarus, what are the consequences in terms of domestic violence and SRHR? Have any of the panelists seen evidence or research in countries that don't have these specific lockdown measures? Another question, I'll ask about 2 to 3 and then we can open it up to the panelists. Another question that we got, what are the cost issues towards access to contraceptives, especially in the global south, when even before the COVID pandemic, accessing and the increasing cost of accessing SRHR services have reduced the methods in which women can access services. So what does this mean for the cost towards contraceptives? And the last question I'll ask for this specific round is, on the one hand, we have panelists that mentioned that, we're seeing a delay in marriages as a result of COVID, but then we have other anecdotal evidence that's suggesting that there are increases in child marriage. Can we predict that kind of what's going to happen next, or what are these contradictions, or what are we seeing there? And I'll open it up to the floor.
I'm happy to go ahead. Also, if you want to put my video on, that's fine too. I think this question about the first one you asked about what can we expect in places like Belarus where there hasn't been a lockdown is a really interesting one to think about. My first response is that, the economic consequences are still going to be felt. This is a global world that we're dealing with. And so even though Belarus maybe didn't have a lockdown, the economy can't have stayed steady or improved. I haven't actually looked at their numbers, but I'm assuming that there are also economic consequences there, and that those will certainly affect marriage and affect people's sense of stability, and that will have repercussions for domestic violence, certainly. And then just kind of while I have the floor, I think this question about early marriage as a result of the economic crisis that people are feeling is a good one, and I would really love to get good data on that. This might be a kind of situation where we see diverging trends within specific settings, where some groups of maybe the least or the most disadvantaged in the population will see a trend towards earlier marriage for that reason, but then the better off will see a trend towards later marriage, and how that balances out overall is a question. Is sort of an empirical question, but I think both of these things can exist simultaneously. So I'll turn it over to my co-panelists for other responses.
Yes, I think I would like to come in and, particularly speaking to the cost. There's the cost of not only contraception, because it's the entire package of service provision. So the cost is definitely much higher now. And the challenge is that, as I had mentioned earlier, that the resources are now prioritized to the COVID response rather than key SRHR services. So this is likely to bring about a barrier. If it's unaffordable, then it's no longer accessible. But the challenge with that is that we'll then expect high cases of unplanned pregnancies. We also have very limited comprehensive sexuality education going out, meaning that the unplanned pregnancies, just multiply, both in those who, are probably in unions and then the younger group. We are also expecting an increase in HIV infections, and not only because there's a violence and abuse happening, but also because the routine access to ARVs or to access the routine medication may be a major challenge at this time. Not to mention the delays that are likely within the global system of logistics. There's a lot of challenges even moving cargo from one point to another. So these are all, other, factors that are likely to affect cost. And this is why I had mentioned that, the champion parliamentarians that we are working with are already aware of these issues and are, trying to work hard to secure the space of SRHR as we speak. I think there's an SRHR bill that is ready for tabling in Kenya, even though there's a lot of pushback from the traditional opposition who wouldn't like to see this. We have the same happening in East African community that is likely to impact 6 countries in East Africa, and similar efforts are happening also around the continent. So this could be ways to mitigate and try and bridge that and shift that cost away from the end user, which is definitely likely to be a burden if left unattended. On the other issues, I think my co-panelists have mentioned. I just wanted to highlight that apart from the exploitation, there is also the feeling among young women that they are forcing themselves to engage in activities sexual activities that they would have otherwise not done, simply because it's an alternative to survival, especially for those who may have lost their daily wages. So this is an area to watch because, despite the lockdowns, there's still so many things that are happening within the communities. And just to highlight that, the situation is not, when we look at a few things that have probably worked and that we should continue investing in are things like the community health strategies that were always in existence, but now that with COVID, the kind of community monitoring and tracking and reporting of issues has also heightened. So it is a surprise that, in absence of the mainstream regulation or regulatory mechanisms, the community monitoring system is gaining its ground. And if we get to empower that, then we can learn more about what can be done better to resolve these issues. So I thank you, and that's it. Over.
Thank you, Caroline. I'll go to the next question, and this one is specifically for Agnes. So Agnes, in your presentation, you mentioned that cash transfers targeted as women are a way of increasing women's bargaining power. But as we know, there's also evidence that sometimes this can lead to intimate partner violence, especially if there are no interventions targeted at men at the same time, especially now when they also have lost their incomes. So how can we optimize benefits to households while also reducing these tensions? Double targeting, how do we package this nuanced targeting as a policy option? I'll open the floor to you, Agnes.
Thank you, Leva. This is a very good question. And in pre-pandemic times, my colleagues have studied whether there are increases in domestic violence because of cash transfers. And actually, by and large, the evidence seems to be that there may be isolated cases. It's not, I wouldn't say that it's a general case that the woman being the recipient of the cash transfer increases IPV. However, I think what I'd like to go to the part of the question which asked what type of complementary programming can be done. So what what these same colleagues found, so Shalini Roy, Akhtar Ahmed, John Harinot, and others found that in Bangladesh, when WFP provided cash transfers and food transfers to some treatment arms, so this is in an experimental evaluation, that they also had a treatment arm which provided behavior change communication. The treatment arms which had behavior change communication experienced actually long-term declines in intimate partner violence. So it would be nice to see, for example, in the COVID context, if some type of emotional support could also be provided to help reduce IPV. And this was working mainly, we think, through improving the woman's self-esteem and her bargaining power. In another cash transfer program, however, in Mali, it was not feasible to give transfers to the women. So the transfers actually went to the men. And it turned out that in polygynous households, it reduced the incidence of intimate partner violence, probably because the transfers helped to alleviate stress. So I think my takeaway from this is that intra-household dynamics are really context specific. So you need to tailor the intervention to the particular context to make sure that you don't do any harm, because I think that do no harm should really be the underpinning of any type of intervention.
Thank you so much, Agnes. And I'll end it with one last question open for all the panelists. This came through, the problem is very real. Households who already are struggling economically have now lost opportunities to earn income and are now forced to lock down in small spaces that they call quote unquote home. So they probably don't have the luxury of private intimacy, the absence of self-help support from community or other organizations. There are low absence of safety nets and social protections and many other negative repercussions. All these can increase domestic violence, physically, emotionally. So where do we all start?
So I have an idea, which is that even if households are locked down, and I'm seeing this among my family and friends in the Philippines, where I am from, there is still some measure of contact with the outside world. For example, through the medical system, through the social workers, through neighborhoods. It's not how households may become more isolated, but there is some people are still allowed to go out to the community. It would be good to provide some services at this point of contacts so that households that are at risk can reach out. It's easier said than done, but whether it's through remote, through mobile, through community groups, which now scale up to a virtual platform, I think we all need to be creative to make sure that services continue to be delivered, even if, as Caroline pointed out, a lot of the services are being directed to the COVID response rather than to other things which are also important.
Yeah, I think I can come in. I can come in at this stage. And I think where we start, maybe there's not one place to start. We may have to think of a multifaceted start point because there is the start point at, I mean, we could say downstream, I mean, where the real issues and the real people are. We have the midpoint, because the midpoint is necessary to process and bring to reality all those things that are constructed in the abstract systemic world. So at every stage, there needs to be change. I mean, something has to steer, something has to give at each of these levels for the change to be realized. Because it's one thing for the women to be empowered and aware but lack access to the necessary livelihoods or cash transfers that they require to make a difference. It's also another thing to just have, say, project based cash transfers, whereas there's a multitude that did not get into the shortlist of the project to benefit. So a systemic change in that case would be necessary for universal access to be assured. So it is definitely a challenge, but you know, more reason why this multi-sectoral approach, or you know, mix of you know, the knowledge, the academics, and the practice needs to see what change we are able to effect at which point, so that the wheels or the you know, the gears can get moving in tandem. This is my take. Thank you.
Yeah, I would just like to quickly agree with Caroline. I think that she said it the best, that there's probably not one place to start, that we need to start on all fronts, and we need to start now so that we can really understand the depth and the breadth of the challenges facing families and figure out the best ways to help meet the huge diversity or you know, array of challenges that exist.
All right, well, thank you very much, Sarah, Carolyn, and Agnes, for an amazing discussion of the several issues that we have. We're going to be, of course, recording this, and later on we'll be able to access this presentation on our YouTube channel, looking at Women's Empowerment Lab.mcgill.ca. You'll be able to get that, as well as a summary of the discussion. So thank you very much. I also would like to take the opportunity now to talk about our next upcoming webinar, which will be next week, and actually it's quite linked to some of the issues and the questions that were raised today. We'll be actually talking, some of you were mentioning about intimate partner violence and some of these issues that may arise during COVID-19. Well, our next webinar will be on gender-based violence and COVID-19, and it will happen on July 2nd, that is on Thursday. So on this, I'd like to thank our three panelists for a great meeting, and all of you for coming and visiting us. And I'm inviting you to July 2nd for our next one on COVID-19 and gender-based violence. Thank you very much.